Mm-hmm.
If you don't have family members, you won't have affected family members. So it's very difficult to deal with that.
Absolutely. Couldn't agree more.
If there are no 3 members in a family, how are you going to do that?
Thank you for the great discussion. Thank you, Thomas. And
You're welcome.
Before we move on, I'd just like to say that whoever is online joining us, please feel free to just ask questions anytime. It's my great pleasure to introduce my longtime friend and mentor in pancreatitis, Ashok Saluja from the University of Miami. And we asked him to talk about recent advances in pancreatic cancer therapy, but he said he will talk about only advances in pancreatic therapy. Ashok, the floor is yours.
Thank you. Thank you, Nicholas. Thank you more even Peter for inviting me here. It's really a pleasure to be celebrating 10th anniversary of Hungarian Pancreatic Study Group. I had a pleasure of coming here several times, and it's one of the favorite places to come. But at the same time, I must congratulate you and your group that you have done. I've been watching it for the last 10 years at least. That there's a remarkable progress in what you have accomplished in such a short time. So congratulations. So I've been asked to tell about recent advances in pancreatic cancer therapy. And I added the word our journey, because there are too many advances and my presentation is very biased. So I'm going to just talk about what we are doing rather than covering the whole world, which is an impossible task for a 20-minute talk. So I'm going to just tell you a little bit about what we are doing in this day. One is not moving. I'm not doing something wrong. Oh, thank you. So I don't need to tell this group that if I was giving this talk 5 years back, I would have told you that is the 4th leading cause, 5-year survival is 8%, and there are 48,000 in Americans who get pancreatic cancer that year, but it's not 5 years back. So here is the data. It's not 4th, it's 3rd leading cause. It's going to be very soon 2nd leading cause. We had in 2020 more than 60,000. Bottom line, it's increasing like a wildfire. It's just like California fires, Nicholas can vouch. It's really, really sad story what's happening with pancreatic cancer. Something needs to be done. It's again, while we have made difference in all other cancers, most all other cancers. Look at colorectal cancer, prostate cancer, breast cancer, even lung cancer. All of them are trending downward, thank God, except pancreatic cancer. So how do we change this course? Well, prevention, but we can only prevent if we know what causes it, right? I don't know, maybe just having too much of Coca-Cola. I see Peter drinking a lot of Coca-Cola, so maybe that, but we don't know that. So don't stop. So early detection is the holy grail. We are making a lot of effort on that. And we have many talks here on this, except still there's nothing we can really show. Better surgery, of course, that's making some difference, but only like 20 or 25% of the patients can undergo resection, 75% of the patients cannot undergo resection. So what we need really is, even after surgery, you need to give some neoadjuvant or adjuvant therapy. So we need a better systemic therapy. So what do we have right now? There are 2 main drugs are FOLFIRINOX, which is a mix of 4 different chemo drugs. And with that, the median survival is about 11 months. What's the second one? Mix of Abraxane, which is nab-paclitaxel, and gemcitabine. A little bit safer drug than FOLFIRINOX, but still 8 months median survival. Those are not acceptable situations. Even with all of these drugs, most patients die in 1 year, 75–80%. So something needs to be done. We need to have new therapies, new drugs. So that brings us to somewhat what we are doing or what we started to do as many of you know, because when I came to Hungary many other times, I gave talk on pancreatitis. I started my life in pancreas as pancreatic physiologist, pancreatitis researcher, and that's where in late 90s, early 20s, we started thinking about heat shock proteins. These are the proteins which were discovered by Ritosa, the Italian scientist. And the basic function of these proteins is whenever we have sublethal stress, these proteins go up and then they prevent subsequent lethal events. There are many other functions, but that's simply put, that's what heat shock proteins are supposed to do. It's a very conserved mechanism. Every living organism has that. And there are many different kinds of heat shock proteins. The one we are going to concentrate in this talk is heat shock protein 70. So over the years, we have shown that if you upregulate heat shock protein in mice and rats and other, any animals, and you can do it many different ways. You can do it with chemicals, you can give stress, whatever. If you have a lot of heat shock proteins, then the animals don't get as much pancreatitis. So bottom line, that these proteins protect acinar cells, protect cells from dying. It prevents inflammation, necrosis, apoptosis, you say it, and these proteins will protect that. So that's what we published. We have probably 20-some, 30 publications in that area and still ongoing. And we studied mechanisms and all those kind of things. But then in early 2000s, 2002 or 3, we started thinking about pancreatic cancer. That why pancreatic cancer cells don't die. We want to get rid of them, but they don't die. One way or the other, they come back. And we have learned from our work in pancreatitis that if you have more of these heat shock proteins, cells don't die. But 2 and 2 together, we thought, okay, maybe the cancer cells have too much of this good thing, HSP70. Indeed, that's the case. We do the Western blot, you take all the cell lines, or you take the tumors, fresh tumors, compared to normal cells, they indeed had 20, 30 times more HSPs. And that's true for many different studies. Not only this was one of our first studies, but others have confirmed that multiple times, that indeed HSP70 is high in cancer, pancreatic cancer technology. So if that's the case, very simple, blocking HSP70 should kill tumors. And indeed, that's what we have. We took MIA-PACA cells and other cancer cell lines, give RNAi and other genetic approaches, cells start dying. But the problem is you cannot give all these genetic approaches to mice or patients to cure tumors. So we need a small molecule drug. And problem is there's not much known. There are no small molecule drugs for heat shock protein 70. So we showed in early 2000s, 12 years back, that Tryptonite, which is a diterpenide, the structure comes from this plant in China. And this compound is used for last 20, 30 years in China, has been used very heavily for anti-inflammatory, all kind of other things, though there's no systematic study on that. So we were the first one to show that this compound is very potent inhibitor of heat shock proteins in tumor cells. And you can see at nanomolar concentrations, it prevents them. Not only it prevents the expression of HSP70, it kills tumor cells without affecting much normal cells. Not only it does in cell lines, it did that in mice also. As you can see, the control mice have big tumors. You give Tryptonite, the tumors were much smaller. Some of the animals didn't have any tumors. So that was, that's when I moved to Minnesota, and there was a great interest in that, except there were two problems. It's not soluble in water, Tryptonite, and you cannot get a patent on that. And if there's no IP, there's no drug, no one is going to ever explore this and use this, unfortunately. So we modified the compound and we made a prodrug, which since I was in Minnesota, we named it Minilite. And it's water soluble, and the university has a patent, and that brings to my disclosure slide that I'm the inventor of Minilite, and which has been licensed to company Mini-Amrita, and I am part of the company. So we use this compound Minilite and show that indeed it's very, very effective. Mice not treated with Menlite with tumors died, in about 40 days, whereas the ones which were treated, they lived long, long time. Same was true when you use S2013. It's very, very aggressive tumor. These mice died in about 25 days, whereas Menlite treated mice lived for a long time. And last model in this is that when we use patient-derived tumor, PDX, and put that in mice, show if you don't treat them, this blue line, the mice grow, tumor grows. If you treat them, they don't. And even when the tumors are very big, you start Menlite on them, and again, in about a couple of months, the tumor shrank. So based on these studies, Menlite, obviously is also very effective in many other cancers. Actually, we are doing several trials, clinical trials. I'm going to show you just a snippet of that. We are doing a trial in gastric cancer in Korea, in AML, of course, in pancreatic cancer, and we are going to probably start soon in osteosarcoma also. So this is our initial phase 1 clinical trial. You can see this is a waterfall plot, and you can see that it shows, somewhat efficacy in several patients with different doses, and then you get partial response and stable disease in several patients. And this is actually a gastric cancer patient. You can see after one cycle, there was a significant decrease in tumor burden right here. You can see after treatment, before treatment, and so SUV after one cycle decreased from 37.5 to almost half of that. So then, since Menlite is not like pancreatic cancer is not one disease, it varies from different things, different treatments. So we decided to, eventually what's going to work in pancreatic cancer is combination of drugs. There's no single drug which is going to cure pancreatic cancer or make a big difference. So we thought, okay, let's try this with standard of care, which is gemcitabine and Abraxane. We used low doses, about 40% dose of gem and Abraxane, plus low dose of Menlite. You can see that the combination is much, much better than each individual component in survival. And there's a lot more data on this, and this is actually coming out soon in Cancer Letter. I'm going to switch gear a little bit and get out of Menlite work and just tell you a little bit more about some of the other things we are doing in the lab. So one of the questions is why chemotherapy and immunotherapy is ineffective in pancreatic cancer. Immunotherapy, in the last 10 years has really made a big difference. For example, in some of melanomas and others, is quite effective, whereas in pancreatic cancer, it really has not done much, maybe 1 to 2% efficacy in patients. So why is that? Why these drugs, whether it's chemo or immuno, does not work in pancreatic cancer? There are many reasons. One of the reasons we think is the stroma. That it's a cancer's shield against immune attack and the drug permeability. If you look at that, that's what typically a pancreatic cancer looks like. There are very few tumor cells, but 70–80% of this is really stroma. And we think it's the stroma which prevents infiltration of immune cells and drugs. So we need to, if you want this to be effective, we have to get rid of this. So we studied a little bit of that. We have several studies in this, and how, on this pancreatic stroma. I'm going to show you just a couple of slides on that we believe that is the NF-kappa B in stromal cells, which is really responsible for that. So for this, we take, it's a very simple experiment. We take pancreatic cancer cells, KPCs, and mix them with either the wild type pancreatic stellate cells or P50 minus, whereas this, NF-kappa B is not functional. You combine with that. So either this and this or this and that, you put them in mice. And what we find is that when you have KPC alone, tumor as expected grow. When you mix them with wild type pancreatic stellate cells, big tumors. But if you have NF-kappa B knockout, P50 knockout, the tumors were much smaller. Remember, again, these are NF-kappa B knocked out, not in tumor cells. This is in stellate cells, which obviously are a significant part of microenvironment in pancreatic cancer. So there's a lot more data on that. This was published in Gastro maybe 3 years back, and where we show that the pancreatic cancer stroma creates an immunosuppressive environment, and stromal NF-kappa B mediate of this immunosuppressive environment. And targeting NF-kappa B or its downstream mediators, because it's difficult to knock down NF-kappa B in patient setting, the CXCL12 could emerge as a good therapy. There's another therapy we've been using just recently to show how we can affect it. One of the studies, not our study, but a drug company has tried pegylated hyaluronidase in pancreatic cancer. So what they are showing is that if you mix chemotherapy with PEG hyaluronidase, there was less tumor. They have done phase 1, phase 2, but they failed in phase 3 trial this drug. So it was promising, but it didn't work out. So we tried a different approach. We used a molecule known as DAN. It's a glutamine, it's a long name, it's abbreviated. This compound, this is a small molecule, is an inhibitor of hyaluronic acid. HA is a main component, one of the major components of stroma. So we thought, okay, let's get rid of this and see what happens. And you can see when you get rid of hyaluronic acid, there's less collagen, less HA in the tissues, and the tumor volume and tumor weight was much smaller. Not only the tumor volume was smaller, when you give immunotherapy itself, as expected, it didn't work. DAN did some effect, but if you combine DAN with immunotherapy, remember now with DAN, you don't have as robust stroma, so the T cells, the immune cells can enter and make a difference. So same thing was a survival benefit with this. You can see when you have combination of DAN and anti-PD-1, there was a significantly better survival benefit compared to without DAN. So from these studies, and there are many more studies which are in JCI, that hyaluron is a pancreatic tumor microenvironment, and its inhibition, which inhibits infusion or efficient infiltration of cytotoxic T cells. And if you get rid of this HA with the DAN or any other treatments, then PD-1 therapy and chemotherapy will become more effective. Lastly, I'm just going to spend a minute telling you the last part where we want to study gut microbiome, that how it promotes tumor growth and how getting rid of gut microbiome can also alter immune response and decrease tumor burden, and at least in mice, and there are trials going on. So here we plotted subcutaneous KPC cells, very, very aggressive tumors. And you can see that the tumor, this red line is when tumor grows, but if you give antibiotics to the mice before you implant the tumor, and you can see the bugs are gone and the tumor burden is much, much smaller with antibiotics compared to saline. And there, and you can see here, this is the liver mets. Actually, one of the major effects of getting rid of microbiome is that it prevents metastasis. You can see with antibiotics, compared to saline, the liver metastasis was much, much lesser than otherwise. So what our data is suggesting that microbiome accelerate primary and metastatic PDAC. And if you eradicate microbiome, it will, I didn't show you all the data on this, but it will potentiate the efficacy of established therapy, including both chemo and immunotherapy. So, my friends, we need to have really a war on pancreatic cancer. Not the war we are having 200 kilometers from here, and that's very unfortunate. So what we really need is not fighting with each other. We need to fight together against pancreatic cancer. And for that, we need to use all kinds of armament, whether it's immunotherapy, get rid of stroma, surgery, yes, Gemabraxane, antibiotics, mineralite, and many more. So we need to use every armament we have to get rid of these pancreatic tumors. That's where we need to have a war. That's where we need to fight, not kill each other and not use our tanks and planes to destroy other countries and other civilizations. With that, I want to acknowledge the people who really did the work and our funding agencies. And thank you again, Peter and Nicholas, for giving me the opportunity to present some of our data. Thank you.
Thank you very much. Fascinating talk. My first question would be, I'm very much interested in the stroma work. I also had a chance when I was in Liverpool to work a little bit of stroma cells in gastric cancer, and I realized that how many MMPs, insulin-like binding proteins, growth factors they are secreting. And we always thinking about the structures and the cell divisions and everything, but not the functions of these kind of cells. So are you aware any kind of therapeutic approach which was like added to the general treatment, which inhibiting, for example, these kind of MMPs or such stromal functions around the cancer cells?
You know, as you very well pointed out, like in gastric pancreatic cancer, you know, stroma is not really one component. You know, there's collagen, there's stellate cells, immune cells, hyaluronic acid, MMPs, there are many, many different components. The question is, how can we get rid of all of them? And I mean, that's almost an impossible task, but I think even if we can get some of them, like we are showing hyaluronic acid or, you know, others, and I'm sure there are studies on MMPs also. I think, if I'm not wrong, Raghu Kuluri used to work on that. I think we might still be doing some of that, but these things, you know, will make a difference. I think eventually the goal will be really one way or the other to get rid of stroma, or at least make holes in that, if not get rid of that.
Thank you. So,
Congratulations, Ashok, and I would like to ask you questions about mineralite. It's nice to see that the number of tumors that it attacks against is increasing. You started out with pancreatic and HPSG, so it would be nice to see more clinical data. But my question relates to the effect on HSP70. Does it act on other heat shock proteins? And how specifically does this affect the tumor cells? But obviously, heat shock proteins play an important role in normal cells as well. So that would be detrimental for those cells to inhibit heat shock proteins.
Jolton, very interesting question. There are two parts, two answers I want to give. First of all, mineralite or tryptonite, what we are showing is that it's not inhibiting constitutive HSP70. It's the inducible HSP70. We call it 70, it's really like 72 or 73, which is the inducible form. It's not there in normal cells. It's there. That's why you can take a mice and you can give as much mineralite you want to give, or not as much. It's eventually it's a toxic compound. It's very toxic. So it can, but it does not affect. We have given this to mice for a year and they still live. So that tells you that does not affect HSP70 and normal.
What about other inducible heat shock proteins like HSP
90.
Oh, 32. 90 is there constitutively. So
Yeah,
what about 32?
I think it has some effect on 27. I don't know about 32, but it does not inhibit 90, because that's the other big player in cancer field is 90. And actually, when you inhibit 90 with other compounds, there are many other compounds inhibit 90, HSP70 as a compensatory goes off the roof. So that's why HSP90 trials mostly have not worked because of the compensatory effect. But coming back to your thing on Menolite, actually, initially we started this work on Menolite because we wanted to inhibit HSP70, and it does. But it turns out that Menolite has many other effects. It's definitely inhibit HA and collagen. We have published paper, and I think it's in Clinical Cancer Research 3-4 years back. And it's an NF-kappa B inhibitor. And actually, it starts with SP1. That's the main factor where it starts, and then everything else is downstream. So its mechanism is fairly complicated. There are tons and tons of paper how tryptonite inhibits almost everything in life and some more.
Thank you.
Thank you.
Thank you very much, Ashok. That was fantastic. Thank you.
Thank you. Thank you.